Welcome to the Deep Dive. Today, we're digging into something pretty specific and, thankfully, quite rare in pediatric health. Aortic and arterial aneurysms.
Yeah, basically these are bulges, like weak spots in the walls of blood vessels, but happening in kids.
And because they're not common, they bring, well, some unique challenges.
Exactly. We're pulling our information today from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition. Good stuff in there.
Right. And our mission really is to kind of extract the crucial bits about these conditions in children, the types, the causes, how dangerous they are, and the treatment approaches.
We want to give you a solid understanding, a real feel for it, without you feeling like you're drowning in, super technical jargon.
Okay, sounds good. Let's start by unpacking aortic aneurysms first. Now, the book defines these as a widening of the aorta, the main artery, more than 1.5 times its normal diameter. But normal for a kid. That's not as simple as for an adult, is it?
That's a really key point. We don't have these, universal standard sizes locked down for kids' aortas. But recent studies using imaging, like CT scans, they've given us really valuable data. It's based on things like the child's age, their gender, whereabouts in the aorta we're looking, and their body size, their body surface area.
Okay.
And that's super important, especially when you think about genetic conditions that might affect the whole aorta.
And the immediate takeaway, the sort of concerning part, is that these aortic aneurysms in kids are generally seen as pretty dangerous. That definitely gets your attention.
It really does. I mean, the number of times we see reports of rupture, the aneurysm actually bursting or thrombosis where blood clots form inside, it's high enough that usually intervening early is considered the best way forward.
Makes sense.
And you also have to remember, kids who have other active illnesses going on, things that might be contributing to the aneurysm, they face the highest risk, but also the surgeries can be much more complex for them.
Right, okay. So looking at why these aneurysms actually develop in the first place, what are the main sort of buckets or categories of causes?
So the book lays out a few main areas. Genetic factors, developmental issues, sometimes called idiopathic, which just means we don't know the exact cause, infections, inflammation, and trauma.
Okay.
Let's maybe start with the genetic causes. They're often quite, clearly defined.
Right. And the book points to several key genetic syndromes. Marfan syndrome is the first one mentioned, caused by a problem with the FBN1 gene.
Yeah, and what's interesting there is that this gene defect messes with how the body makes and regulates a protein, fibrillin-1, which is a key part of our connective tissue. And this leads to problems with how collagen, sort of the body's scaffolding, links together properly. So a major vascular thing you see in Marfan, kids and adults, is this widening of the aortic root, right, where the aorta leaves the heart, and also the thoracic aorta in the chest. And while it might be less common overall in kids compared to adults, a pretty significant number of children with Marfan, the book says maybe 50 to 83% show some aortic widening, and maybe 20% have actual aneurysms.
And how do they usually approach treating Marfan in children? What's the plan?
Well, often doctors will recommend medications, things like angiotensin receptor blockers, ARBs, or beta blockers.
Right.
The goal is really to try and ease the stress on the aorta, slow down how quickly that aortic root might be enlarging. There's also a really severe form, neonatal Marfan, which progresses super fast, often from new mutations, not inherited ones.
Wow. Okay. Next up, Loeys-Dietz syndrome. Sounds like another genetic one.
It is, yeah. Another inherited connective tissue disorder, autosomal dominant. It comes from defects in the TGF pathway that's involved in cell growth and stuff.
Okay.
What's really typical here is something called panvascularopathy, basically. It affects blood vessels all over the body. Yeah. So you often see aneurysms in the descending thoracic aorta, the peripheral arteries, and also tortuosity. The arteries get really twisted and winding. And these patients can also get dissections, tears in the artery wall. Interestingly, those can happen even when the aorta isn't massively dilated, unlike maybe in Marfan.
And the progression sounds pretty serious.
Very much so. They tend to grow and unfortunately rupture relatively quickly. So surgery is often considered earlier. And similar to Marfan, meds like beta blockers and ARBs are often part of the plan, trying to slow down that widening.
Then there's Vascular Ehlers-Danlos syndrome, linked to the COL3A1 gene defect.
Right, and that gene makes type 3 collagen another really vital structural protein. The big worry with this one is the higher risk of spontaneous rupture. Not just blood vessels, but other hollow organs too.
Oh, wow.
Aortic root and thoracic aortic issues like aneurysms or dissections can happen, but maybe more often in older kids with this syndrome. But the really critical thing, trying to surgically repair these vessels is incredibly tough.
Why is that?
Because the arteries are just so fragile, so prone to tearing, surgeons have to be unbelievably careful during any kind of reconstruction. It's high risk.
Got it. Okay, tuberous sclerosis is also mentioned. I usually think of that more with like brain issues or skin signs.
You're right, it often affects multiple organs: brain, eyes, kidneys, heart, skin. Vascular problems are less common, but they definitely happen.
Hmm.
In kids with tuberous sclerosis, it seems like the abdominal and thoracic aorta are affected more often than, say, arteries in the arms or legs. There have even been reports of ruptures, sadly leading to deaths in infants and children. Figure 186.1 in the book shows this quite clearly: multiple sort of balloon-like aneurysms in a child's aorta.
And what do they think causes these vessel problems in tuberous sclerosis?
Well, the exact how is still being figured out, but there's evidence of what they call dysplastic and degenerative changes. Basically, the vessel wall doesn't form right and then weakens. It's linked to problems with the TSC1 and TSC2 genes. Interestingly, though, the book does note that surgical repair of abdominal aortic aneurysms in these kids might actually be, relatively speaking, less risky than in some of the other genetic conditions we just talked about.
The book also gives a quick mention to other rarer genetic syndromes. Sounds like a really complex area.
It is.
Let's shift gears then. Developmental or idiopathic aortic aneurysms. What's the story there?
Right, so these are thought to start during fetal development, but we can't, currently anyway, point to a specific genetic cause.
Okay.
For thoracic aortic aneurysms that don't neatly fit into those known syndromes, there's this sort of growing idea of looking at a wider range of physical features, trying to gauge the risk of the aneurysm growing, and guiding treatment, maybe including meds to slow growth. It's also interesting. Kids who have other systemic things going on, issues with their face, eyes, skin, they seem to have aneurysms that are more likely to enlarge quickly. Figure 186.2 shows a good example, a sort of bulge in the upper abdominal aorta in a young baby.
And sometimes these can be linked to blood flow problems, right? Like turbulence.
Yes, exactly. Post-stenotic turbulent flow. That's where blood flow gets all chaotic and high pressure after squeezing through a narrow spot that can cause the aorta downstream to dilate. You see this most often in kids with a thoracic isthmic coarctation, a narrowing of the aorta in the chest. Sometimes fixing the coarctation itself can help deal with the aneurysm that formed because of it.
Okay.
The book also talks about narrowings in the abdominal aorta, thought to happen because of abnormal fusion way back during embryonic development. And because these often involve the arteries going to the kidneys and gut, it suggests there might be some hidden genetic factors at play too, which makes surgical repairs pretty tricky.
Okay, next category. Infectious aortic aneurysms. That sounds quite serious indeed.
Historically, yeah, they were a bigger piece of the pie for pediatric aortic aneurysms. Thankfully, less common now. The most frequent connection is with umbilical artery catheters used in newborns. These aneurysms usually look like little sacs and can pop up in different parts of the aorta or the iliac arteries down in the pelvis. You can see examples in figures 186.3 and 186.4.
And what kind of bacteria are usually involved?
Often Staphylococcus aureus and Staphylococcus epidermidis, and these tend to show up in the first couple of years of life.
And what's important when treating an infectious one?
Well, if you need to use a prosthetic graft, a synthetic tube for the repair, it is absolutely vital that the infection is completely gone first.
Right.
But unfortunately, that's not always possible when you're dealing with one that's growing fast or has already ruptured, and it's still infected. The book also mentions some rare cases of infections around the aorta, periaortic infections that aren't linked to catheters.
Moving on to inflammatory aortic aneurysms, the book says these are pretty uncommon in kids.
That's right. The main one we think about here is Takayasu aortoarteritis, and, much more rarely, Kawasaki disease. Even rarer causes like Behçet's or lupus are mentioned too.
Let's talk a bit more about Takayasu aortoarteritis.
Okay, so this is a chronic inflammatory disease. We don't know the cause, idiopathic. It affects the aorta and its main branches. It actually starts in the outer layer of the artery, the adventitia, and works its way inwards. Eventually, it leads to narrowing, blockages, and in the later stages, aneurysm formation. It tends to hit older kids and adolescents.
What are the signs?
The early symptoms can be quite vague, headaches, fever, feeling breathless. High blood pressure is common, along with weaker pulses in the neck or groin. Surgical treatment, whether it's open or endovascular, can work well, but ideally you want to do it when the inflammation is quieted down with medication. That lowers the risk of problems later at the surgery site.
And then Kawasaki disease. Most people probably link that to heart issues, right? Coronary arteries.
You're absolutely right. It's a systemic inflammatory thing affecting younger kids, probably an infection triggering it in genetically susceptible children. It presents with that classic high fever, rash, red eyes.
Yeah.
And while coronary artery aneurysms are definitely a huge concern because of clot risks, the abdominal aorta is actually involved more often in the first year of life in these kids.
Oh, interesting.
Yeah, and an important point. Any surgical repair on the aorta or peripheral arteries should generally be avoided when the disease is active. Too much risk of complications where you make the connections.
Okay.
Figure 186.10 actually shows an aneurysm in the brachial artery in the upper arm from Kawasaki. The book also notes these aneurysms can sometimes shrink on their own with immunosuppressive treatment, especially if IVG is given early.
Okay. Final cause category. Traumatic aortic aneurysms.
Relatively rare in childhood, thankfully. Direct penetrating injuries are often fatal, sadly. But deceleration injuries, like in car crashes, can cause tears in the aorta's inner lining. These can then become pseudoaneurysms, basically, contained leaks.
And treatment.
In older teens, where the aorta is getting close to adult size, sometimes endovascular methods can be used. But open surgical repair is definitely an option, too.
So with all these different causes and types, what are the actual open surgical techniques used for aortic aneurysms in kids?
Well, the book highlights a few main strategies. One is aneurysmectomy with interposition grafts, basically. You cut out the weak bit and replace it with a tube, a graft.
Okay.
Another is non-anatomic bypasses, where you create a new route for blood flow around the aneurysm. And then there's aneurysmorraphy, which is repairing the aneurysm wall itself, either by closing it or opening it up, cleaning it out, and reinforcing it. Figure 186.5 shows an example treating an aneurysm in the thoracoabdominal aorta with a bypass graft. These ops can be really complex, especially if important branch arteries, like to the gut or kidneys, come off the aneurysm itself.
Yeah, you have to be careful there.
Extremely. Maintaining blood flow to those vital organs is paramount.
And the grafts themselves, anything specific for kids?
Absolutely. Size is critical because the child's still growing. Right? The book gives some general size guidelines for different age groups, from tiny grafts in newborns up to almost adult sizes in older teens. Material-wise, Teflon, or EPTFE, is generally preferred over Docrin.
What is that?
Docrin has this tendency to stretch or dilate over time after it's put in. Cryopreserved homografts from human donors can be used sometimes, but we don't have as much long-term data on how durable they are in kids. And if those branch arteries come right off the aneurysm, doing a non-anatomic bypass is often the best bet to keep blood flowing to those organs.
You also mentioned aneurysmorraphy. When would that be used?
It's used less often in kids, and its exact role isn't super clear for pediatric abdominal aortic aneurysms. But if you can fix the underlying reason for the dilation, like in that post-stenotic situation we talked about, where you've repaired the narrowing, then maybe just fixing the existing aortic wall could be enough.
But not much long-term data.
Yeah, not a lot, no. Not to really confirm how well it holds up long-term in kids. Closed aneurysmorraphy, where you kind of fold the wall in on itself, is usually only for smaller, more uniform aneurysms. Not good if there are clots inside or if it's just too big to collapse properly.
Right.
In those cases, an open aneurysmorraphy might be better, where the surgeon might remove part of the wall before repairing it, like shown in figure 186.2.
What about the less invasive stuff? Endovascular repair stents and things inserted through blood vessels. Is that common in kids?
Its use is pretty limited for most abdominal aortic aneurysms in children. The exceptions might be those traumatic pseudoaneurysms in older teens whose aortas aren't going to grow much more. Or emergencies, yeah, like a sudden rupture. TEVAR, thoracic endovascular repair, might be an option in really carefully chosen patients, right age, right size. But you have to be cautious if the child has a progressive arteriopathy, where their arteries are likely to develop more problems over time.
So overall, how successful is surgery for these aortic aneurysms in children?
Yeah.
And what about follow-up? Is that important?
Generally, surgery for abdominal aortic aneurysms in babies and young kids can be successful, but it really needs very specialized skills and careful thinking about growth, location, branch arteries, all that.
And follow-up.
Absolutely essential. Long-term follow-up is mandatory. The book cites a study showing about 10% of kids who had successful aortic aneurysm surgery needed more operations later on.
Okay.
So ongoing monitoring is really key.
Okay, let's switch focus now. Let's talk about aneurysms in other arteries, not the aorta, in children. The book says their natural history isn't as well understood.
That's true. And how we classify them isn't quite as neat as for the aorta, but the basic worries are the same. Risk of getting bigger, rupturing, forming clots, or sending clots downstream, causing blockages.
So intervention is still often needed.
Often, yeah, because of those risks. And while these non-aortic ones are super uncommon in kids, they often share similar causes to the aortic ones: infection, inflammation, genetics, trauma. Polyarteritis nodosa and neurofibromatosis type 1 are two conditions specifically mentioned as sometimes being linked. The book then kind of breaks it down by which blood vessel is affected.
Okay, where do we start? Extracranial cerebrovascular artery aneurysms.
Yeah.
So neck arteries going to the brain.
Exactly. They're defined by being significantly wider than the normal carotid arteries. True aneurysms here are often thought to be genetic, inflammatory, or traumatic pseudoaneurysms, maybe from blunt trauma or even medical procedures nearby, as you can see in figure 186.6.
And what's the most common sign?
Usually a pulsatile mass in the neck. You can actually feel it throbbing.
And the risks sound pretty significant again.
They are. Things like Horner syndrome affecting the eye and face problems with cranial nerves, serious neurological issues like stroke, even rupture. It all points towards early surgical treatment, usually being the recommendation.
What kind of surgery?
Often aneurysmectomy, removing it, followed by an interposition bypass, using a graft from the patient's own body, like the hypogastric artery from the pelvis, or maybe a prosthetic one. In some very specific cases, if the brain's blood supply network, the circle of Willis, is complete, just tying off the vessel ligation might be considered.
Any other options?
Endoluminal therapy, using covered stents put in via the blood vessels, might have a role sometimes, but these procedures aren't without risk potential for cranial nerve injury or stroke.
Okay. Next, splanchnic artery aneurysms supplying the abdominal organs.
Right. These most often come from infections, mycotic aneurysms, inflammation, trauma, or connective tissue diseases. Figures 186.7 and 186.8 show some examples.
Symptoms.
Common ones are abdominal pain, sometimes GI bleeding. Pseudoaneurysms from liver or spleen injuries might sometimes just clot off on their own, or they can be treated with endovascular embolization, blocking them off from the inside.
And surgery.
Ideally, you want to exclude the aneurysm and restore normal flow. But if the vessels are really fragile because of infection or a genetic issue, ligation tying it off might be the only option, relying on collateral blood flow. Where exactly the aneurysm is matters too, especially if it's in the superior mesenteric artery supplying the intestines. Ligation is trickier there.
Then renal artery aneurysms going to the kidneys.
Yeah, generally linked to connective tissue disorders or congenital vessel problems like dysplasia in neurofibromatosis, shown in figure 186.9.
How serious are these?
Well, their clinical importance, how they behave over time, the rupture risk, it's all a bit less defined. They often look like little sacs where the artery branches. Actual rupture is pretty unlikely.
So what are the treatment options?
It's complex. Can involve removing the aneurysm and repairing the artery directly, doing a bypass, or even reimplanting the artery into the aorta. For bypasses, again, the hypogastric artery is often a good choice. Other techniques like ethanol ablation or coil embolization might work for smaller ones further out.
What if it's too complex?
Rarely, a nephrectomy removing the kidney might be needed. And small ones found by chance during other surgeries might just get a closed aneurysmorrhaphy, stitching the wall closed.
Okay, moving out to the limbs. Upper extremity aneurysms, arms and hands.
Common causes here are trauma, maybe from catheters, and inflammatory things like Kawasaki disease. Figure 186.10 shows one. They often show up as a throbbing mass you can feel, maybe with pain or tingling.
Do they rupture often?
Non-infected ones rarely rupture. But the big risk is clots breaking off and blocking blood flow to the finger's distal thromboembolism. That's why early intervention is usually warranted.
And the fix.
Usually removing the aneurysm if it's below the armpit, then restoring flow maybe directly, maybe with a vein graft, or sometimes just ligation if there's good collateral flow. Generally low-risk surgery. For aneurysms right in the hand, you might need specialized microvascular techniques.
And finally, lower extremity aneurysms, legs and feet.
The iliac arteries in the pelvis are most common here. Similar causes to aortic aneurysms, as figure 186.11 illustrates, often no symptoms, but sometimes abdominal pain or a mass.
How are these treated?
Aneurysms of the internal iliac can often just be tied off safely good collateral supply usually. But common or external iliac aneurysms need more complex repair. Resection and reanastomosis, grafting, bypass, maybe mipplication. Usually use prosthetic grafts sized for growth. Homografts might be an option if there's
Gotcha.
infection.
What about further down the leg?
Femoral arteries, pseudoaneurysms, or true aneurysms in the thigh, and popliteal aneurysms behind the knee, they often need early surgery because of the high risk of clots. Using the patient's own vein for reconstruction is preferred. Aneurysms way down in the tibial arteries, extremely rare. Figure 186.12 shows one.
Wow, it really sounds like managing any of these pediatric aneurysms, wherever they are, needs a whole team.
Absolutely. You really need that multidisciplinary approach for the best care. Vascular surgeons, pediatricians, radiologists who know vascular imaging, anesthesiologists, everyone working together closely.
And what about the overall outcomes for these non-aortic aneurysms in kids? Does the location matter long term?
It seems to. The experience from the University of Michigan mentioned in the book really backs up the need for long-term follow-up.
Yeah.
Their data showed that while about 15% of aneurysms in the abdominal organs needed a second operation later, they had no repeat interventions after treating aneurysms in the arms, legs, or those neck arteries going to the brain.
Interesting difference.
Yeah, it really highlights how the long-term picture can vary depending on exactly where the problem was.
So, okay, wrapping up this deep dive, it feels like the main message is that pediatric aortic and arterial aneurysms, they're rare, yes, but they are serious conditions. They have this really wide range of causes, and the treatment has to be very personalized, often complex, usually surgical.
That's exactly it. You absolutely have to consider the child's growth potential and the specific features of that particular aneurysm. Those are the critical factors guiding every decision.
And it really leaves you thinking, given all these very genetic roots, developmental pathways, and with research always moving forward, what kind of advancements might we see down the road? Maybe in diagnostics, finding these earlier or more accurately, or perhaps less invasive treatments. Things that could really make a significant difference for these kids and their families. Definitely something profound to mull over. Thanks for joining us for this deep dive.